Welcome to Prevent Child Abuse Kentucky's No Hit Zone training. I'm Dr. Kelly Dock. I am a general pediatrician by trade. I work as a hospitalist at Norton Children's Medical Group, and I'm a professor of pediatrics with the University of Louisville and proud board member of Prevent Child Abuse Kentucky. So thank you for your commitment to learning more about this program. Talk briefly about the origins of the No Hit Zone project. We'll talk about strategies to use as part of the No Hit Zone response, and then a little bit more about interventions. I'm going to talk a little bit about my story and how I got involved with this project in particular. So I used to think of myself as this brand new young physician. I had studied hard, I had worked hard, and I was ready to go do this job that I had been working toward for a long time. And I felt really prepared. I was ready if someone stopped breathing in front of me. I was ready if someone was seizing. I was ready to help with asthma attacks and all those sorts of things. And what I quickly learned is that I was not so well prepared for situations where behaviors were escalating in terms of the families that came into the office where I worked. And when caregivers were threatening their kids with hitting them or spanking them, I just did not have the tools in my toolbox. I did not receive training on how to handle that and how to de-escalate these situations. And so we all approach these situations with different life experience, different personal beliefs, different professional training. And some of the things that we talked about today may pose a challenge for you and may feel uncomfortable. And that's okay, because when I was initially approaching these situations, it made me feel very uncomfortable because I really wasn't sure what to do. And so, typically hitting was not the first thing that I would encounter. I would be in the back of the clinic. And, back in the Stone Age, we used to write on paper charts. So I would be writing on the chart, and I would be teaching medical students and residents in our clinic, and then also trying to take care of patients and families. And I would usually hear a warning sign before hitting actually happened. So I'd be sitting back there and you'd hear it come. It'd be, come on, you two, get back here. I'm gonna whoop you if you don't hurry up, right? Something along those lines. Or if you don't sit still, I'm gonna spank you. And I would feel the hair on the back of my neck stand up. And I would find myself in those early days burying my head in my chart and pretending like I didn't hear it, because I honestly did not know what to do. And then I kind of start looking around at my partners. I'd start, praying that Mel, the nurse who's worked there for 20 years, who knows all the families that come into our clinic, would like magically appear and make it all stop. Or that the nurse would take this family down to Dr. Patel's, exam room, so that then it wouldn't be my exam room and I wouldn't have to, handle the situation. But I was really unprepared. But then I started to realize that, my students and my residents are looking to me as the leader in terms of how to handle these situations. And, my patients who were already in exam rooms down the hall, who were hearing these threats happening, and I wasn't doing anything about it, that was almost sending a message that I was okay with it, and I wasn't. So I really had to learn a lot of skills and strategies to figure out how to navigate these situations. And so I think all of us who work with children and families really have the ability to take a very public stand on hitting children and interpersonal violence. And so you will hear me use the words spank and hit and corporal punishment interchangeably. And that is somewhat purposeful. A lot of folks use different terminology, but I will use them interchangeably somewhat purposefully, because spanking is hitting. But all of us who care for children and families, again, are able to make it through a no-hit zone, are able to take a very public stand on hitting children and again, hitting for all ages. And certainly spanking is very much a cultural norm. It has decreased over time since the 50s and 60s, but it's still quite prevalent. And so I think we can look at other social norms and how those particular norms have changed over time to inform our conversations with patients and families and clients today. And so perhaps I'm the only one in the audience because now I'm older and older, but and attendees are younger and younger, but was anyone put to sleep on their stomach by their parent as an infant? A couple of nodding heads, right? Not everyone, and that's okay. But I know I was, right? Because my mother was worried that if I threw up in the middle of the night, that I would choke if I was on my back instead of my belly. Now, this is certainly not the advice that we give to families these days, right? This is not our social norm anymore. And it's not only sleeping on our back, it's also all of the things that go along with safe sleep and a safe sleep environment. Because we know that by sleeping on your back with all of those safe sleep environment strategies, we decrease the risk of harm to infants. We decrease the risk of sudden unexpected infant death. So we have changed in the advice we give to families over time based on research. Similarly, did anyone ride in the back of a pickup truck as a kid or ride without a seatbelt? One of our favorite stories is traveling down to Florida. We would drive to Florida each year for spring break to go visit my grandma who lived down there. And my brother and sister and I would all fight to ride on the hump in the back seat of the car. And goodness knows the hump did not have a seatbelt. But now our social norms are pretty different, right? My neighbors and community members are going to be looking at me if my kids are hanging out of the minivan or I'm riding, with the trunk up and they're hanging out or not wearing their seatbelt. And we've carried it even further. Now there are 5-point harnesses and booster seats and kids stay turned around in the car for long, extended numbers of years. And so our social norms are very different. And it's because we know that restrained passengers have a much lower risk of serious injury or death than unrestrained passengers. So our advice has changed over time. How about this? And if you can't recall smoking on an airplane, perhaps you can recall when it was the norm to have a smoking section and a non-smoking section in a restaurant. I think all of us probably at least have some familiarity with that. But I would say that's not our norm anymore. I think it's very few and far between where you find a smoking and a non-smoking section in a restaurant, because we know that by avoiding secondhand smoke and by avoiding smoking, we reduce our risk for certain harms in terms of cancer risk, cardiovascular health, all those sorts of things. So regardless, the advice we give to patients and families has changed over time. And so I'm going to share with you just a tiny bit of the research on corporal punishment. There's lots and lots out there, but perhaps the most important relationship that I want for everyone to understand is this very strong relationship between corporal punishment and physical abuse. So that does not mean that everyone who is spanked is abused, right? That is not the case. However, corporal punishment is certainly a risk factor for child abuse. And so again, as folks who work with children and families, we want to promote and encourage strategies that avoid the likelihood of physical abuse. And so there's a definite association between those two things. And this is based on, if you'd like to look it up, Liz Gershoff is very well published in this area. She did the 2 huge meta-analyses that looked at dozens and dozens of studies over several decades and found relationships and associations between corporal punishment and many detrimental health outcomes for children. And so you can see the list of these. Increased aggression, antisocial behavior, mental health problems, lower self-esteem, et cetera, et cetera, et cetera. And so again, as those who want to reduce risk, we want to encourage children and families to avoid things that would increase the likelihood of these particular outcomes. This is another slide that essentially speaks to the same thing. This particular slide, so again, looks at that those meta-analyses and the associations between spanking and negative health outcomes. And this slide in particular eliminates any studies that where caregivers used implements or tools or where the spanking was particularly harsh. And so it's meant to reflect the associations between good old-fashioned spanking, meaning swatting on the buttocks with a hand, as opposed to some studies which included information of more severe forms of hitting. And the associations still hold true. And the strongest association, again, is between spanking and a child becoming the victim of physical abuse. When we look to professional organizations and where they stand on this particular topic, the one that I go to as a pediatrician, first and foremost, is the American Academy of Pediatrics, who in the last couple of years has been very clear on this topic. Their report on effective discipline suggests that parents should not use corporal punishment, including hitting and spanking, either in anger or as a punishment for or consequence of misbehavior. And in fact, there are multiple professional organizations that recommend this same thing. And again, this is because of this very strong association between spanking or hitting and physical abuse. There's a remarkable Canadian study that looked at substantiated cases of physical abuse and found that over 75% of those cases started out as an episode of physical punishment. And so this idea, because I genuinely believe that when parents spank children, they don't go into that with the intent to cause physical abuse, right? That's not how that goes. Unfortunately, things escalate and get out of hand and can lead to physical abuse. So the no-hit zone, where does all of this come into play? So no-hit zones actually were started back in 2005. Dr. Lolita McDavid at Rainbow Babies and Children's in Cleveland, Ohio, started the first no-hit zone. And since then, there has been remarkable spread, particularly throughout the medical community, but we are also seeing significant generalization to other settings. Norton Children's, we actually started our no-hit zone in 2012. And I will share with you, the map itself is not 100% updated, but as of this month, there are actually 312 registered no-hit zones, and lots of other advocates, meaning folks have signed on as an advocate, but perhaps they have not been able to fully implement a no-hit zone in their location just yet. And so this is a slide that speaks to that generalization to other settings. So a prosecutor's office in Dane County, all the city buildings in Staunton are actually no-hit zones. There's been, the first no-hit zone was established at Shiloh Baptist Church by Reverend Daryl Armstrong. And there has been significant interest in no-hit zones, particularly in Louisiana, in schools, as well as child advocacy centers. So it's been really exciting to see this idea and program expand beyond the medical community. And so here's the dilemma. And so please tell me if this is a situation that you've ever faced, either personally or professionally, the one where parents or adults become angry, start to raise their voice, or even hit a child or another adult in your presence, and you're not sure what to do. And I'll tell you, this happens professionally for me, but more than, quite often, it happens personally for me. And it's usually in Target or in Walmart or in the grocery store. And I hear it from 2 aisles over, right? I hear that angry parent, and it's, it's usually rush hour, and so it's busy, and the kids are cranky, and parents are probably, heading home from work and trying to do a million things. So it's already a stressful situation. And so, those hairs stand on the back of my neck the way they did when I was first working in clinic. But now I find myself navigating my cart toward that aisle instead of burying my head in my chart and pretending like I don't hear it. And so the goal of this training, again, I'm not going to give you all the answers to every single situation you will ever encounter, but hopefully we will all put some tools in our toolbox that are common for how to approach situations where folks are escalating. And so, we all want to have a safe and caring atmosphere, both as a place that we work and for the children and families that we care for. And so we want to have a lower frequency of disruptive behaviors within our no-hit zones. And we also want to send this clear message against interpersonal violence for all ages. And so I just want to be really clear that we're not talking about responding only when hitting happens. We need to all be mindful within our no-hit zone of those precursors to hitting. So whether that's yelling, whether that's jerking on an arm, those sort of warning signs, because I will tell you that the quicker you attend to an escalating situation, the more likely you will be in de-escalating it. I put this slide in here to illustrate just how important signage is. We want everyone who enters the no-hit zone to know that it's a no-hit zone without a doubt. We want it to be very, very clear. And so having permanent signage that's very easily visible to anyone who enters that space is really important. I can't stress that enough. And in some ways, it's really helpful when you as a staff member have to approach someone because it takes some of the pressure off. It's not me judging you and what's going on here with the situation, but you've probably seen our sign, we're a no-hit zone, and because I work here, I'm obligated to say something. So let's talk real specifically about what we mean by a no-hit zone. And I will tell you that this is somewhat purposefully pretty generic so that it can apply to all environments and all ages. So a no-hit zone is an environment in which no adult shall hit another adult, no adult shall hit a child, no child shall hit an adult, and no child shall hit another child. And some of these are easier to negotiate than others, right? And so again, we just want this to apply to all settings, all age groups. And it really fits in quite nicely with many organizations who have an already existing anti-violence policy. This language really couples nicely with most of those policies. And so this really has to be a team approach. This can't be, one person. It can't be Kelly Doc running around all over the hospitals and the clinics looking for people who are escalating and approaching them. It really has to be a team approach. And so when hitting or the precursors to hitting are observed, it's everyone's responsibility to interrupt the behavior and communicate the policy. So hopefully through this training, we're informing everyone about the no-hit zone policy. We'll all have our eyes and ears looking for situations that might compromise the no-hit zone. And hopefully we'll all put some tools in our toolbox for exactly how to respond. And then we'll help each other out. So general guidelines, trying to be non-judgmental. So this makes some sense, right? If a caregiver is escalating and things seem to be headed in not a great direction and I'm approaching that situation, I'm going to probably make much more headway if I say, how can I help you, than I am with, what is going on here? What is wrong with you? Right? Like that is not going to go well. That is only going to further escalate the situation. Modeling effective interventions when appropriate. So I find that most of the time when things are escalating, it has to do with some kind of mismatch between a child's level of development and a parent's expectation for what their behavior should be, right? And so sometimes there are situations where I can model effective interventions or help inform the caregiver that what their child is doing is appropriate and expected for their age. So the example I'll give is, teeny tiny exam room, 18-month-old, right? They kind of explore the world with their mouth and their hands, right? That's what they do. So yes, they want to look in the trash can. They want to turn the water on and off 49 times. They want to open and close the door 35 times, right? And the parent just wants them to sit still on the exam table. Well, I'm actually kind of worried if an 18-month-old is sitting still on an exam table for 20 minutes, right? That's not normal behavior. And so sometimes there's a real opportunity to talk to the parent of the 18-month-old who's getting frustrated. Oh my gosh, look how curious he is. He has those motor skills to be able to turn on and off and how to turn that door handle. That's so exciting. Gosh, do you have anything in your bag that we could get him to play with just to kind of move his attention to something else? Or you know what, maybe I have a book or a coloring page that you guys could work on together. And so sometimes there are opportunities to help grow a parent's toolbox, right? As parents, goodness gracious, I need extra tools in there all the time. And then trying to have conversations with caregivers out of the earshot of others, including the kids, so that caregivers aren't embarrassed into being confrontational. So at least in the clinic with the long hallway, a lot of times when things would escalate, it would mean that a parent would be talking loudly outside in the hallway, kind of for all to hear. And so a strategy that was very effective is, could we please go sit down? I really want to help and figure out what I can do to make this better. Whereas if a caregiver was approached in the middle of a busy hallway, it may escalate things further. And then thanking parents for respecting our policies. So interruption. If you listen to nothing else in this whole entire talk, please listen to this slide and the next one. So this is the key tool that can be used to de-escalate a situation when caregivers begin to raise their voices, curse, or show other signs of stress and inappropriate behaviors that occur prior to any hitting. Okay? And I will say your calm, sympathetic, physical presence is the most effective response. Your calm, sympathetic, physical presence is the most effective response. Because it's not even so much the words that I'm saying, but when I put my chart down and I stop teaching a medical student and I come to your room and ask, how can I help? It's not even so much the words I'm saying, but the fact that I'm coming to you and attending to the situation that lets that family know I hear what's going on in here and I'm not okay with it, right? Now, again, not all of us, run toward the escalating caregiver. I know that I'm fairly non-confrontational by nature, and so this is not something that came easily to me. I had to really think through what are some different things that I can say that are non-judgmental and that are pretty neutral, right? So can I help you with something? Would you like me to take your child to get a book or a sticker or walk down the hallway and give you a minute? You've been waiting for a while. Let me see when you can expect for it to be your turn. Most 2-year-olds can't sit still or behave for long periods of time. Would it be helpful if I found something for him to play with? Simple, direct, neutral, non-judgmental. But I think it's helpful to think about these phrases in advance so that you have them in your toolbox and you're ready with them. So we're going to go through a couple scenarios. This is not meant to be rocket science or really complicated, and so I welcome your participation. So you're a team member working in an office. You observe a caregiver yelling at her 2-year-old and 3-year-old children while in the waiting area. What do you do? offer something for the kids to do to keep them busy. And then always consider stresses the family may be under. So I always found that the boiling point in our clinic was about 3 o'clock because likely a toddler had missed a nap, they'd forgotten to bring a snack, and they were still waiting on vaccines, and there was someone getting off the bus down the street or across town in 10 minutes, and they had to get out of there. That is usually where the boiling point was for our clinic. And it may be different. It may be different in whatever setting you happen to be in. But certainly there are additional stresses that oftentimes lead to these escalating situations. And sometimes it doesn't have anything to do with the actual child that is currently present. And then consulting additional support staff if they're available and appropriate. So, this could be a social worker, this could be a chaplain. Actually, chaplains have a great deal of de-escalation training. I don't think I fully appreciated that until I started doing this work and working with the Child Abuse Task Force at Norton Children's. They have a tremendous amount of de-escalation training. So asking for help from the other folks who are in your office. I also want to stress the team approach. So again, in this scenario, there was someone who was getting escalated in the waiting room. If they're then coming back to a different area, then we need to make sure that the folks in the back are aware that this is a family that has shown signs of stress so that we can have our antenna up to really be paying attention to whatever particular room they're in now to be looking for, are there additional signs of stress? And again, responding immediately to disruptive behaviors will help de-escalate the situation. Continuing to sit back and hide in the chart tends to allow things to continue to escalate rather than de-escalate. And it may take a few times before you're comfortable with this, and that's okay. It did for me too. I kind of liken it to when I first started talking to families about childhood obesity. I didn't feel comfortable addressing it. I wasn't sure what to say. But I realized that it was really important for me to talk about it and get comfortable with it. And now I am. And so in a similar way with these situations, I didn't feel comfortable. I didn't know what to say, but I know it's important for me to address it for the safety and health of the children and families that I work with. So again, the goal is to interrupt when you see disruptive behavior, not simply ignore it. So sometimes things escalate really quickly, or sometimes we just don't recognize that things are escalating and a child is hit. And so in that case, what do you do? I think this is where the signage can be really important and helpful. And again, thinking about these phrases ahead of time, because this isn't necessarily something that rolls off the tip of your tongue, right? So for the safety and protection of everyone in our office, we participate in a no-hit zone. I'm obligated to say something. And then what can I do to help, right? So, it's not me judging you and what's going on. We have a no-hit zone, and so I have to say something. And then that offer of assistance. And I liken this to a no smoking zone, right? I mean, if we have a no smoking zone and someone lights up a cigarette in the waiting room, we're going to say something, right? That's not a healthy thing to do or be exposed to. And so I think we can get to the point where we think about this similarly. Or you may have seen the posters in our waiting room. Our office is a no-hit zone. We ask that you refrain from hitting and keep conversations quiet out of courtesy to the other families. So again, at least within this zone, within these four walls, this is the expected behavior. We don't hit here. We don't smoke here. We don't bring guns here. All those sorts of things. Another scenario, you're walking down the office hallway. A mother yells at her child, yanks him by the arm, and hits him several times. He's a client waiting to be seen. What would you do? That's what we just talked about, right? So it's the intervention, right? Intervene, notify the mom that the office is a no-hit zone, offer assistance, and then again, letting the other team members or other folks who are in the general vicinity who might be interacting with the family know about the incident so they can also be more aware. And then depending on the setting, documentation of the incident may or may not be applicable. I'll tell you, at least within the healthcare setting, families certainly travel between the outpatient world, the inpatient world, perhaps a specialist and whatnot. And so, if there's one documented incident where a family had to be, or a family was notified that the area was a no-hit zone, then it's one isolated incident. But if the primary care provider starts to see that there are two or three, then certainly that might be a signal to the primary care provider to delve into that a bit more and perhaps offer some assistance. So what if the mom responds with, well, who are you to tell me how I can or cannot discipline my own child? Because she's right. Goodness knows being a parent's the hardest job I've ever done, way harder than being a doctor. It's the toughest hat I wear. And so I'm not trying to step into your role as a parent, but this facility is a no-hit zone. We don't allow that behavior here, and it's for the safety of everyone in our facility, right? Acknowledge you respect their role as a parent or caregiver. Again, very difficult, challenging job. Sympathize with the frustrations and stresses they may be experiencing. And then when appropriate, talking about alternative types of discipline. I will say, I would not hand someone who you've just approached with an intervention on we're a no-hit zone, and here's a brochure on discipline, right? Like that is probably not going to go over very well. That adult is probably not going to be very receptive. However, depending on the setting you're in, depending on the relationship you have with a family, and whether or not it's one that is continuous over time, there certainly may be an opportunity to discuss alternative types of discipline at a later date when things are not heated, right? So other considerations. So I just want to stress that if a person becomes angry or you are personally concerned about your own personal safety, then that is outside the purview of the no-hit zone. The no-hit zone does not want you to put yourself in harm's way. And so the usual folks that you would reach out to if you were concerned for your own personal safety apply. So whether that's security, whether that's the police, whoever that is, that's outside the purview of the no-hit zone. Okay, another scenario. So this is to illustrate that there are places in different settings where adults may take children to spank or hit them. And so being aware of where those more quiet, private places are, such as the bathroom. So you hear crying coming from the bathroom 2 doors down. You identify that it is a child and a caregiver in the bathroom. The child's crying and you hear what sounds to be the caregiver hitting the child and verbally scolding them for misbehaving. What do you do? Taking a bathroom break doesn't help you avoid the situation in this particular scenario. Okay, so perhaps you go to the bathroom and knock and ask, is everything okay in here? The caregiver opens the door, reveals a crying child who appears to be about 3. You offer to take the child on a walk and let the parent have a moment and let the caregiver know that this is a no-hit zone. You ask if there's any additional assistance you can offer. And then this team approach of letting others who are in the nearby vicinity or who may be interacting with the family during the particular visit about what has happened. So if you get no response from your knock, please request that the caregiver open the door. Can you please open the door? I'd like to help. So after you report the incident to the rest of the team members, you return to check on the welfare of the child. You observe the caregiver hitting the child repeatedly as she pulls her toward the bathroom. You observe the child crying and screaming. So what now? So this is hard. And I think it's difficult to put into written scenarios what level of escalation you might see or hear in a personal interaction. And so I think there are multiple different right answers in this scenario. So one right answer might be to intervene with the caregiver and child once more, explain this location's a no-hit zone. But you may not feel like you've been effective or that you're going to be effective based on your first interaction. And so this might be a time to ask for additional support from other staff who also work in your setting. And then again, this team approach, there's been a second incident. Things are really kind of escalating here. We all need to be aware. And then depending on how you feel about the first intervention and the severity of the current situation, there may be other folks to ask for help from. So whether that's security, whether that's Child Protective Services, whether that's a social worker who works in the clinic. So it essentially, the scenario is to highlight, number one, areas where hitting may be happening that are out of the way. And then 2, asking for help from others who work in the same place that you do. So again, signage is really important. And this is just putting things, pretty simply. So see something, say something, intervene, right? Responding, respecting, reminding. And so just some of those catchphrases again that you may want to have ready to go in your own toolbox in approaching escalating situations. And similarly, so no shame, no blame. We can all do things differently going forward and make no-hit zones a safer place for children and families. So going forward, trying to make sure signage is in good repair, replacing them as needed, Finding a strategy as new team members come on board, how they will complete their training. And then we are working on some materials in other languages. We've started with Spanish, and there may be others to come. These are some acknowledgements. There's a No Hit Zone National Committee that I sit on, as well as others who have been instrumental in leading the way. And I'll point you toward resources, both the nohitzone.com website as well as the Prevent Child Abuse Kentucky website, if you have any questions or concerns.